Good morning. I'm going to get myself started. So we actually have a lot to try and talk about today, some of which is, I hope, going to seem repetitive. And that's intentional. And we're going to go back a little bit through some motor aspects of cerebellum. There are a couple of things that I skipped over because of time on Friday that I'm going to try and put in now. And we'll talk about a couple of clinically important issues in the cerebellum. And then we'll focus on sort of the non-motor pieces because they're comparably important and very less frequently thought about. So where do we sort of intellectually place the cerebellum so far? Is it a sensory organ? No, but does it get any sensory information? Yes. So it makes use of sensory information. Is it a motor output structure? Not directly, but is it related to the motor system? Yes, and what does it do? So when you take your finger and make that circle, what are you using the cerebellum to do? You're using it to basically guide through feedback about the position of your hand, how you're making that movement, and you're also using it to guide the planning of that movement because you didn't have to think about, am I going to stop back at the top? You just do that. And everybody, when I asked you to make the circle, stopped back at the top sort of as the obvious piece. That was the initial plan, and you've executed it. So you've gathered information, you've made use of it in modulating a motor output. It is not truly sensation, it is not truly motor output, it's a modulator, okay? How about for the vestibular information? What does it do? So where it gathers that information, okay? And then it uses it for what type of motor functions? Well, what do you need to do based on how your vestibular information comes in? What are you using it for? Somebody say it out loud. Yeah, posture and eye movements, head movements. You're using it for your change in your pieces of your body in space relative to the world. Okay? What happens if you have miscommunication or inconsistent information coming from the two ears? In terms of vestibular information, you end up with symptoms that you are aware of, but what else do you typically get? Well, that's a symptom. Nauseous is a symptom. But if you look at somebody's eyes, what are you going to see? Nystagmus. You're going to see the fact that their eye positions are going to be changing because the vestibular information from one side of the head and the vestibular information from the other side of the head are in conflict. One of them is driving the eyes in one direction, and the other is saying, slide them back. And then you drive and you name the nystagmus based on which direction of movement? The slow drift down of your head or the quick jerk back up where you smack it against the wall? Which one? Yeah, the fast jerk back to position. That's the direction, okay? So it sits there and it does these modulatory functions for which it needs sensory input. It needs information when you're trying to make that movement. What does it need information? Not just about how my arm sits in space, but what else does it need to know about? If I just put my arm up here, my cerebellum doesn't make a circle. What makes the circle? The fact that I said, put your hand in the air, take your finger out, and make a circle. That's volitional. How does volitional information get to the cerebellum? Pons. So the cerebellum sits, it's got descending information that comes from cortex down to brainstem and into cerebellum. It has sensory information that comes from the brainstem level and from the cord level into cerebellum. And where have we seen its outputs go? Two big categories. Yeah, it's got ascending and descending. And it's going to ascend through what peduncle? superior, and descend through inferior. And what's the output in the middle? None. Okay? And those ascending outputs, what are the two targets we've named? We've only thought about one of them in detail, but we're going to get to the next one on Wednesday. So what are they? The red nucleus and thalamus. And as we've talked about before, thalamus sits between the rest of the world and cortex. So that's going to get us feedback to cortex. And the red nucleus, where does it go? What are two targets that we've talked about for it? So it has rubrospinal tract, right? And inferior olive. And the path to the inferior olive? Central tegmental tract. Is this one, which of these is ipsilateral and which is contralateral? Either of them ipsilateral? Yeah, so the inferior olive and the red nucleus are on the same side of the brain as each other, and this tract is ipsilateral, therefore does not cross. These, the red nucleus and the target and the spinal cord, are on the contralateral side, from opposite sides from each other. And where will this cross? At the level. And the level for the red nucleus? Midbrain. All right. So now we've got that ascending output, some of which is actually going to slide back down and descend, but the rest is going to go on upwards. All right. Now, how about the descending outputs? Where are they going? They're going anywhere? Or why would you have descending output? What are you going to make use of it for? We already talked about it. Posture. Where are you going to control posture? Cord. What else? What's my favorite topic in all of neuroanatomy? Eye movements. Where are you going to control your eye movements? Your brainstem. Okay? The entire circuitry that runs from the interstitial nucleus of the MLF, PPRF for the gaze centers, the vestibular complex that gets the feedback in from the cerebellum and the cerebellum directly into the MLF, prepositus hypoglossus, interstitial of Cajal as the integrators to bring the vestibular movement information together with volitional. Where's the volitional come from? Cortex. Where are the other drives for moving your eyes? Stimuli in space, right? So your visual stimuli, something that catches your eye in the corner of your field that you move to look at, how do you move to look at that? Retina, retino projection. What's the missing word? Tectal. Tectal is which colliculus for vision? Superior colliculus. Superior colliculus is a coordinate generator. It projects directly into the two gaze centers. Okay? So we've got that cerebellar output coming out to modulate those functions. Those are the descending. And to modulate the things that are volitional, it's going to have ascending components. All right? It has, in all of those functions, the same cellular modularity. So here, driven is this sort of, Poseidon's trident, except it's got 4 prongs, is what? Purkinje cell. That Purkinje cell dendrite is characterized by synapses with 2 types of fibers. They are climbing fibers and? No. Climbing fibers and parallel fibers. Remember, parallel fibers are after the synapses that come from the mossy fibers down in the granule cell layer. Those parallel fibers are the axons of granule cells. So we've got that perpendicular, the orthogonal inputs into Purkinje cells. Purkinje cells project to what? To the deep nuclei, which how many there are? 3 to 4, depending on how you count. Fastigial, interpositus, which is actually made up of globose and emboliform, and then dentate. Okay? So we have an inhibitory output to the deep nuclei. Do we have any exceptions? Yeah, there's always an exception. What's the exception? Yeah, there are some Purkinje cells for vestibular and floccular nodulus that project directly back out to the vestibular nuclei, skipping a deep nucleus. What's the advantage of that? Both fast and, yeah, you've now on the feedback loop, you have both excitatory and inhibitory. It allows you to do faster activation and more importantly, faster inactivation of those neurons, because you have an inhibitory input into them, as well as just turning off your excitation. You can actively turn on inhibition. All right. All of the climbing fibers come from where? Where's my? Yep, they all come from the inferior olive. The mossy fibers come from everywhere else. All right. So when we think about that circuitry, we can think about what we call vestibulocerebellum, spinocerebellum, and pontocerebellum. And those are named based on the major inputs. Pontocerebellum, base is pontos. The target will be the hemisphere, and it's for extremity movements and especially fine movements. The spinocerebellum, spinal inputs, the dominant spinal inputs go to vermis, and a bit to the hemisphere. You know where your arm is in space when you make that movement, okay? Same as you know where your fingers are, okay? And that's about trunk position, extremities, and gait. And the vestibular is flocculonodulus, and that's really about head position and eye movement. Now, clearly, head position, trunk position, posture are linked. So these share bits of information back and forth, and they will have some of the same targets. If they're going to have the same targets, where are you going to basically see ascending outputs? You're going to have ascending outputs for this, for eye movements. That's a little bit, but not much. Head position? A little bit. Because if I ask you to turn your head, you have to be able to feed that back to know whether you did it or not. How about posture and trunk? Well, again, you can change your trunk position. So all of this you have to, but most of the components that are done for things like posture and rapid responses are in fact just descending. How about your gait and your extremities? Remember, the intermediate zone functions a lot like the hemisphere, and that's got a lot of ascending. And the hemisphere, is that ascending or descending? Almost all ascending output, okay? If you're going to ascend, you're going to mostly go out through the superior, and if you're going to descend, you're going to go out through the inferior. So let's take a look at these. What do you notice? Yeah, they're brains. So it's a diffusion-weighted image, so the white signal there is what's actually, no, it's a flare image. The white signal there is what's abnormal. So first of all, are the slices in the correct order? You should get really good at this. Are they in the correct order? No. What's wrong? So I've swapped a pair. Which pair? Everybody's pointing like this. Somebody say some words. As we say to like kindergartners, use your words. Top, middle, and bottom right. Correct. That's now in the correct order. All right? So when we go back, what was wrong? How do you know what's wrong? Well, there are two major clues that you can look at here. Okay? So one, you can say, how much non-posterior fossa brain do I see? Okay? Because if you think about it, your posterior fossa, remember, it's that lowest step down as you go the 3 steps from anterior to middle to posterior. So if you only see posterior fossa, you know that you are lower down than if you see posterior, middle, and anterior, right? So that's one clue. What's the other clue? What? Yeah, but how do you know whether you're above or below them? That doesn't tell you much, okay? And how do you know whether you've gone through the upper half or the lower half? That's not as great a clue. How about the structure that's involved in the lesion? You can use shape of the brainstem. Remember? I mean, if I show you a picture of the brainstem, you're pretty good at telling me where we are. So think about that. So if you look here at the top middle, what part of brainstem is it? Top middle, right here. What is this? What does it look like? Looks like pons. What is this? That looks like medulla. How about this? Looks like I can see the bumps right here on the ventral surface. What would those be? One here, yeah, pyramids and olives. So that is medulla. So if you go medulla, pons, medulla, something's wrong, right? And now how about over here? What do we see? Well, that looks to me like I can still see pyramids and olives. I don't see middle cerebellar peduncle. And I don't see superior peduncle, so this actually looks like medulla, and it's in the wrong place. So now when they're in the right place, are they still in the right order? Did I just switch some more? Well, let's look from here. We've agreed that this is pons. What does this look like? Pons. Okay, so those two look like pons. And now let's sort of say, how much cerebellum do I see? So if I draw the line here, that's sort of the boundary there, and here's the boundary there. Let me draw those in. And now where's the boundary here? Well, it's sort of like this and this. So this is smaller than that. So which way should I be going in the cerebellum? Up or down? Up. And in fact, I know that I'm going up because I'm actually beginning to see the vermis here better than I was seeing here. So this is higher than that, and I can say, yeah, that makes sense in terms of that. What do I see here that I didn't see here and I don't see here? The thing here is, what's this? And this? And here, middle cerebellar peduncle. So that means I have to be in the pons. And so this is actually pontomedullary junction. So we've got medulla, medulla, pontomedullary junction, pons, higher pons. How do I know it's higher pons? Well, I have actually, in here, I can actually almost hallucinate. First of all, the ventricle's getting smaller. I can sort of see it turning into an aqueduct, and I no longer have the middle cerebellar peduncle. Remember, the middle cerebellar peduncle doesn't quite come all the way up to the top of the pons. Okay? All right. So when we think about functional units, stepping back, we think about flocculonodulus, hard to visualize on any of those cuts. We can see it in the gross, and we'll look at gross cerebellum today. We're going to cut cerebellum. I'll come through the labs and help. It's going to be responsible for eye movements with connection to brain, posture with connections down to cord. Okay? When we think about those eye movements, there is actually some specialization so that the flocculus and the nodulus, although we think about them as a single unit, are actually involved in different functions. And lesions that hit them differentially can give you different deficits. They have pretty comparable connections in terms of inputs and outputs, yet they end up doing different things. So this carries mostly the velocity information for the vestibulo-ocular reflex. How fast do you have to move? What's the rate of head turning, and therefore how fast do you have to turn in the opposite direction? Whereas this is much more about stabilizing eyes and then plasticity of the VOR. So this is a learnable trait. You can change it, you can manipulate it, you can put basically, you can trick people so you can turn the head and move space, and people can then still begin to track an object and are able to make their response be plastic. And how that happens depends on these structures, but not particularly on the nodulus. It's complicated, though. They have the same inputs based on the structures we've said. They have the same outputs. They have the same circuitry, but they do different things. So what does that mean? Well, I'm either lying, right? Or there's heterogeneity in some aspect of the input information they get, or the target neurons that they send their output to that we don't understand. Maybe the vestibular nuclei have different subsets of neurons, some of which code one type of information, some of which code the other. Okay? These are, clinically important questions. They're experimentally important questions. They're basic neuroscience important questions. How do you build a circuit that does this? Well, it's not just wiring lump to lump, but there is, in fact, massive heterogeneity in there that we never talk about. Okay? Now, spinocerebellum, trunk position, posture, as well as gait. Which of these is going to go mostly up and which is going to go mostly down? The top one goes down, and this one goes up. Oop, that slide was out of sign. So yes, so there are components of eye movements that actually sit in the vermis. They get inputs from the pons and the eye movement system, and they go back out via vestigial. If they go out by vestigial, do they go up or down? Down. Okay? And these anticipate saccades. So when you're making those volitional movements, you do something that essentially conditions the system that says you're getting ready to make a movement, be ready for the next trajectory, wherever that's going to go. Okay? So if they're about saccades, saccades are driven from above. Okay? They're about how you survey space. Surveying space requires that you know what space is. Okay? You know that there is an object in front of you. You know it's a face. You're going to spend your time making saccades between the eyes, the mouth, various other parts of the face. You don't stare at one spot. You can't see the whole face at once. You put it together from the saccade-based image, the inter-saccade-based images. Image, saccade, image, saccade, image, saccade, image, saccade, image. You create that composite in your visual cortex. Okay? So it is driven by visual information. Visual information comes to the brainstem to drive eye movements via the pons. And then finally, our fine motor control, the cerebellum, the part that we usually think about, the hemisphere, that massive input from the basis pontus, and then the outputs and from input from olive, and then outputs to red and thalamus, remembering that the red is going to talk to the olive. So let's say a word or two about the olive. Where is it? Midbrain pons medulla. Medulla, okay? It is the second bump, the more medial bump on the, which surface is this, ventral or dorsal? Ventral. So this is the pyramid, here is our olive. And in fact, this large squiggle is what we call the principal olive. There are two other olives, and it's interesting to think about them. There's this little piece here, and this little piece here. See them? They look sort of olive-ish, but they're not connected. This is called the medial accessory olive, and this is called the dorsal accessory olive. And in fact, they are functionally distinct parallel circuits. So, this is a concept we're going to come back to in about a week and a half for the basal ganglia. You build a circuit. We started off with the cerebellar circuit. It's got climbing fibers and mossy fibers, granule cells, basket cells, Purkinje cells, and a deep nucleus. You've got that module, and you can use it for a whole bunch of different functions. You can use it for vestibular information. You can use it for posture. You can use it for wiggling your fingers. Okay? You've got that unit, and you can, depending on which set of inputs you put in, you get out the type of information you need. In basal ganglia, we're going to do that, but here there are, in fact, distinct circuits. And if you look, depending on exactly where you are in cerebellar cortex, you are going to use the, and I can't quite read it. Okay, so here is the dorsal accessory olive, the ventral and medial accessory olives, and then the principal olive. And each of them is, in fact, subsegmented, and they connect and project so that they are even furthermore modular to the distinct portions of the deep nuclei they use. So that the granularity of our vestibulospinal ponto is actually even not coarse, is still too coarse. And that probably is part of why you can have one part of the cerebellum, as we talk about it at the gross level, in fact be responsible for multiple distinct functions, is because it's in fact parts of multiple overlapping circuits. And just the last here, the reiteration about the corticospinal. So when we think about it, we have our corticospinal, begins in one cortex, stays on that side until it crosses down at the cervical-medullary junction. We have the cerebellar output. If it's coming from the dentate, what part of the cerebellum? Hemisphere. Goes to the contralateral red and eventually to the contralateral thalamus. Thalamus goes to cortex. But that contralateral red gives rise to the rubro-olivary fibers in the central tegmental. But what's not shown are the separate fibers that cross and descend like this, which are the rubrospinal. Okay? All right. And this triangle here of red olive cerebellum is what's known as Mollaret's triangle. All right, the central tegmental, I think I've beaten this to death. So let me talk a little bit about some malformations because we need to think about them, and they're clinically important and they're developmentally interesting. So there are two types of Chiari malformation. If you read older books, they will talk about 4. Types 3 and 4 are no longer grouped with 1 and 2. So type 1 is essentially a common variant that can cause symptoms and can in fact require neurosurgical intervention in order to treat. It's characterized by low-hanging tonsils. So what does that mean? Well, what's the tonsil? It's that little nubbin down the inferior surface close to the midline, not where the vermis is, because does the vermis come all the way down to the inferior boundary of cerebellum? No. So they are close there. They sit, where would they sit relative to the brainstem? Dorsal or ventral? Dorsal. They'd sit up against the dorsal surface at the junction of the low medulla and the spinal cord. If they are low, where will they end up displaced to? Into the foramen magnum. What happens if you put too much tissue in the foramen magnum? In addition to the cervicomedullary junction going through the foramen magnum, tell me 2 other things that go through there. Yeah, so cranial nerve 11. Back to the very first lecture. We start making CSF in the ventricular system from the choroid plexus, fills the ventricular system, it leaves the ventricular system through foramen of Magendie and Luschka. It's around the brain. Is it around the cord? Yes. How's it get down there? Travels down through the subarachnoid space through the foramen magnum. Okay? So if you put too much tissue in there, you can block, eventually you can squeeze blood vessels and give ischemia, but you can also just block CSF flux. If you block CSF flux, what will happen to the pressure inside the brain, inside the head? It'll go up. PV equals nRT. Okay? It's an ideal gas, essentially. You have increased the volume because you're making CSF and you're not letting it exchange. Pressure goes up. What do you get as a symptom? Headache. So episodic headaches, sometimes positional, are characteristic for Chiari type 1. And you can get lower cranial nerve compression. Why? You've got sort of everything is squeezed down into this small space. So how do you treat it? You make the hole bigger. Okay, basically take off the posterior boundary of it, and people get better. They are no longer symptomatic. You can't try and yank everything up and tie it up and hold it up. You just make the hole bigger. That's a relatively benign type of lesion. People often present with headaches and eventually get worked up or found to have it and can get referred for neurosurgical intervention. Chiari 2 malformation. Yep. Years. They usually don't have risk of sudden death. It's not like a the colloid cyst of the third, where you can trap it, because what happens here is that you've got the CSF space around the brain. So you're making CSF, you're blocking one of the exchange paths, but you still have your resorptive capacity, so the pressure increases are much smaller and much more, they're relatively transient because you can compensate better. It's usually, they tend to recover. I don't, actually, yeah, I mean, they mostly get better. They don't have particular big deficits. They have a little bit of weakness sometimes. Sometimes they can get, depending on where it is, they can get some, spinal accessory weakness and some shoulder weakness, but it usually comes back. So the Chiari type 2 is a far more complex malformation. It is both a brainstem malformation, a cerebellar positioning malformation, and it is associated with a myelomeningocele in the lumbosacral region. They have a small posterior fossa with a low torcula. Those of you who read the reading know what the torcula is, because we're going to talk about it in the second half of the lecture. Okay? Anybody want to volunteer? What's the torcula? So it's that convergence of sinuses where you come from the superior sagittal and join the straight and generate the two transverse. And that essentially marks the boundary of the posterior fossa. If it comes from the inferior end of the superior sagittal sinus, where the superior sagittal sinus hits the straight sinus, where does it have to be? Give me another landmark. Think about the superior sagittal sinus. Where does it live? The top, yeah, people are moving their hands like this. Words. Give me a landmark. Left, right, midline. Midline in the superior boundary of the falx. Remember, the superior boundary of the falx is going to curve. What is the superior what is that going to eventually hit? The tentorium. So now we've got that point where the sinus in the falx comes down, hits the tentorium. We have the short, straight sinus down the midline of the tent. Those come together. A point is called the torcula. And that's going to essentially say, where is the midline point for the tentorium? That's going to say, what's the roof? What's the top of the posterior fossa? Okay? It's a very easily, unambiguously defined landmark. They have that, and they get caudal displacement, downward displacement of brainstem, especially medulla. So here is a midline cut through a brain of a young child with a Chiari 2 malformation, and you can see a whole bunch of things. First of all, look at how big the posterior fossa is, and look at where, so this, in fact, is the tentorium. Look how small the posterior fossa is. Cerebellum is actually very small. What's this? Yeah, it's the colliculi. So the midbrain is distorted in shape. Do you see a hummingbird? No hummingbird. All right? Look at the basis pontus. Looks like somebody dragged it and stretched it out. Okay? And then look at what's going on here. This is where the foramen magnum was. That was the anterior level of the foramen magnum. That was the posterior level of the foramen magnum. But look at this. What's going on down here? It's got this funny peg-like piece. Okay? This whole distorted thing is the distorted medulla. Okay? This is a major brainstem malformation. Okay? In putting this together, I realized that I don't think when I talked about the cord at the very beginning, I talked about neural tube defects. Okay? So, just terminology. These are developmental lesions. They are almost always reopening rather than failure to close, so that they are a secondary developmental anomaly. The term you'll sometimes hear is spina bifida. If you just have failure to close the tissue over the neural tube and the meninges are exposed to the surface, it is a meningocele. Okay? It's a hole to the meninges. If you expose cord or nerves and meninges, it is a mylo being the prefix for cord, myelomeningocele. If it is exposed, it is susceptible to infection, but also you have usually not had normal development, and so the distal portion of cord and nerves are abnormal. And what would be typical characteristic symptoms you would expect? Dysfunctions of what? Lumbosacral, most commonly. Bowel sphincter, bladder sphincter, lower extremity function. Okay? Major risk factor is low folate during early, both pre-implantation and early and post-implantation stages of gestation. Okay? And in fact, if you look, bread and other things here are folate enriched just for this purpose. And if you actually look, if you look at the percent rate reduction in neural tube defect, looking across a whole lot of populations. So first of all, there is probably genetically based heterogeneity, which may have to do with folate metabolism and 1-carbon metabolism. But there is a significant reduction in rate, up to 80% or 90% reduction in rate if you supplement food across the whole population. Okay?
Are they all called spina bifida?
No, spina bifida is an old term. It doesn't get used much anymore. They're almost all called neural tube defects. The only other one that has a separate name is if the neural tube defect involves the superior end, you can get what's called anencephaly, where you essentially fail to develop not just the top end of cord, but cerebral cortex and skull. And you usually have I used to have a picture, but it goes into that category of like the picture of the diabetic foot ulcer that people put up on the screen and leave for 20 minutes. I have a picture of an anencephalic. They tend to have what's often described as frog-like faces. So basically from above the orbital ridge downwards has been exposed to amniotic fluid intrauterine, and basically everything sloughs off. So you've got these large bulging eyes and then a downward sloping base of cranium that's exposed. And that gets its own term. That's anencephalic. That's incompatible with survival. So what do you see? Who's normal, who's not? I know that's a loaded question, but so first of all, we have two cuts. Same patient in both scans. What's the level of the horizontal? Pons, upper, middle, lower? Upper. What can you see? Yeah, you can see a little bit of cerebellum. You can see superior cerebellar peduncles, and you don't see middle cerebellar peduncle. Okay? So what's going on in the other side? It's taken it basically, tried to be the same level. It's probably a little higher. Well, there's almost no cerebellum. Look at how expanded this is. And what do you think these are? Those are tiny, stretched out superior cerebellar peduncles. Okay? Now, if you had to make up a name for what the radiologic finding is on this side, what would you call it? What do you think it looks like? Excellent. This is called the molar tooth sign. Okay? Now look at the same patient on the midline cut. And what do you see with the cerebellum? Look normal? It's really small. Look at all that extra space. I mean, you know, look at all that. Massively small. Okay? And in addition, the individual folia don't look particularly normal either. So this is an example of Joubert syndrome. It's one of the more common cerebellar malformations after the Chiari's. They have cerebellar-vermal hypoplasia, which is what you saw there. Sometimes they have aplasia. They have lots of brainstem motor functional abnormalities. They are hypotonic, so floppy babies. They have problems controlling breathing. They have oculomotor movement abnormalities. How come? They're not getting any useful feedback from the cerebellum. Okay? They've got variable other problems. It's an autosomal recessive disorder. There are a huge number of loci that drive it. But what's really neat is that it's actually a disease of the primary cilium. Okay? So, have you guys talked about ciliopathies? Yeah, right. You've heard about it, but you've forgotten everything. Okay? So basically, cilia come in two flavors. There's the motile and non-motile. This is not a disorder of the motile cilium, but of the primary immotile cilium. Over here on the right, doesn't have the central cores, but it has a huge complex of proteins, and many of these are, in fact, targets of mutations that give rise to Joubert syndrome. Why does it give you that specific a function? Nobody knows. So the last to mention is Dandy Walker. Walter Dandy was an early pediatric neurosurgeon at Children's. This is basically loss of the fourth ventricle. This is vanishingly rare, except on standardized exams written by the USMLE. Okay? I mean, I have seen one Dandy Walker case in 28 years as a neuropathologist. Okay? It is very, very rare. You ever seen anybody? Yeah, good. Right, but it's very, very rare in terms of overall incidence. It actually is interesting, and the important thing to know is that it actually has, for families, a non-zero overall recurrence risk, suggesting that there is something in there that probably is an autosomal recessive, and there's not good whole exome or whole genome sequencing in triads to try and figure out what it is. Oh, I'm sorry, there is now. I forgot about this. I pulled this up the other night. So there are these two loci that have been mapped based on overlapping sequences. So it's not out, it's older data, but it's out of a whole bunch of cases. So if you look here, what's missing? Cerebellum. What's missing? Here you've got some further out lateral. So as you're close to the midline, you've got much less than the other. By looking at these, you can figure out there are at least two genes which are expressed in cerebellum. It's not clear that these are what are mutated in any of the cases that have happened. All right. Those are Dandy Walker. Yeah, you've got this whole thing here is the equivalent of your fourth ventricle. Okay? Yeah, it's just, it doesn't fill up with anything. And in fact, it has a thin sort of arachnoid membrane right over it, and then you've got this massive cystic open space. There's CSF in there, but where's CSF live? Subarachnoid. So if it's going to be filled with CSF, there has to be a CSF membrane on the outside of it, right? So I want to talk about non-motor cerebellum until we take the break. So there's a syndrome that was recognized called cerebellar cognitive affective syndrome. Okay? And we're going to talk about these cortical deficits at the end of the week, but they're deficits in executive function. What do you think executive function means? Well, how is it that you figure out what you're going to do when over the course of the week? Do you just sort of get Yes, probably you do. Do you get sort of distracted by the first thing that comes along and, you know, no, you have done systematic thinking and planning, looking forward, hopefully, right? Thinking about what you have to do, what are distractions, what are things that are required if unpleasant, how are you going to balance them, how are you going to make decisions. Visuospatial organization and memory. Where are things in the world and where did you put things? Okay, what is where? And language. And then also personality changes and inappropriate behavior. Okay. If you generally test them, they basically don't come out with very clear specific deficits, but they're just not quite as sharp as they once were. The greatest risk for this is if you have bilateral cerebellar disease, especially in the acute state. Somebody with long, slow degeneration or congenital malformation is not going to have this. This is what happens when you get typically vascular injury in the cerebellum, particularly posterior in the cerebellum. So how do you map this? How do you sort this out? Okay? Well, one way to do it is you do a lot of autopsies and you go back and you try and correlate it with exactly what was known about the patient. But that requires getting people to consent to autopsy, and they have to die. And what happens if they had the lesion and they were 50 years old and they're going to live to 85? You're going to have a really hard time doing that. So what you have to do is you have to basically build really good anatomic maps from imaging, and then you have to be able to translate them into the plane that you care about. Okay? So an enormous amount gets done in terms of imaging research, which is really, how do I know where I am? How do I sort out boundaries? How do I do that automatically so that I don't go out of my mind tracing objects on image after image after image, and then build up volumetric maps of where lesions are? So that's been done, and here's a series of, I don't remember how many, 39 cases of cerebellar strokes, mapping out exactly where the lesions were, and then you can correlate that with who has deficits. So then you can begin to say what drives motor deficit versus cognitive deficit. Okay? And that's where it becomes clear that if you have the anterior lobules, 1 through 5, you have prominent motor functions. You have got the ataxia, the inability to reach the target, the inability to generate the smooth trajectory, the past pointing, all of those symptoms that we think about as cerebellar disease. Okay? The ataxic gait, the inability to balance, the inability to walk in the straight line. If it is further back, lobules 7 through 10, you don't have much motor deficits, but you get the affective syndrome. And if you get it so that you involve if you hit 7 with posterior, you get minor motor, but some motor. So lobule 6 seems to be the boundary. And if you remember, I showed you before when I told you didn't know anything except the primary fissure. The issue is that the primary fissure separates out those things that always give you motor. Here's the lobule. These always give you cognitive, and this gives you a bit of both. So that there's segmentation or separation of functional consequences across this anatomic boundary in the cerebellum. And lots of cerebellum, lots of that inferior cerebellar hemisphere is not particularly associated with motor function, but is in fact much more associated with cognitive function. No, not in this plane. It exists in other planes, and that's the reason that the three-dimensional reconstructions are so important for the imaging, is that you have to look at it in multiple planes in order to know where you are, and that's why doing it automated is a far better mode than trying to do it by hand. John? Vermis and extending out laterally. So it's not just the vermis, because vermis is not particularly involved with the extremities. Okay? So, if you think about them, the anterior and superior surfaces and lobule 7 have inputs from motor systems and spine, and they output to motor thalamus. And the olive projections come from dorsal and medial accessory. Remember that separation of separate olivary domains? Lobule 7 does 7, which gives you cognitive stuff, doesn't have as much motor input as other areas. Its olive, in fact, comes from the principal olive. And as we will see later, it is connected both directly and through thalamus with non-motor components of cortex. So they are, again, parallel loops that give rise to different types of motor control. One is motor control the way we think about it. How do I move my hand? How do I move my foot? But the other is the sort of motor control about what's my decision. What is my output in terms of behavior? What is my output in terms of how I move around in space based on visuospatial information? The last, I think it's the last clinical thing I'm going to say, is about cerebellar mutism. So this is typically seen after surgery, and it's typically seen after surgery in children and adolescents, but very, very rarely in adults. Okay? It's hard to know exactly what the cause is, although it's very characteristic. Some not insignificant fraction, I'd probably say, based on conversations at tumor board, probably about 10% or so of kids who have cerebellar tumor surgery have some degree of mutism afterwards. And sometimes it can last for a while. Sometimes it's a couple of days. Sometimes it can last longer. And it can sometimes last and cause long-term language disturbances. Okay? It's usually transient. There's a component of dysarthria that's commonly a stage in recovery. So what does mutism mean? They don't talk. Okay? No output. Do they understand? Yes. But no output. And as you begin to have output, there's often some dysarthria. So dysarthria is the inability to make the smooth movements of mouth, tongue, airspace that you need in order to generate comprehensible speech. Okay? So that's a cerebellar sign. Persistences may continue. It typically is associated, more higher risk factor seen in kids whose tumor involves the brainstem, midline location. It's not got a single anatomic site. Usually not. Usually not. It's just about language. So it's not a physical single site. It's a circuit deficit, and this is a concept we're going to come back to over the course of our discussion of cerebral cortex as well. But what's really critically important is some combination of the dentato-thalamocortical circuit. So what is that? Ascending or descending output? Ascending, comes out from the dentate, goes to the thalamus, ipsilateral or contralateral thalamus? Contralateral thalamus, same way it goes to the contralateral red, and then from that thalamus up to the cortex. And in fact, by looking at fiber tracing using DTI, one can show that the change in the cerebellar output fibers from on the right cerebellum. Where does the right cerebellum go? Left side of thalamus and left side of cortex. We'll talk about this on Friday, but which side of cerebral cortex is mostly associated with language generation? Left in almost everybody. So that there is something about those fibers. They are slightly injured. They're not transected, but they're slightly injured, usually probably from retraction. As they get yanked, normal cerebellum gets yanked out of the way to be able to visualize the tumor to get it out, that disruption, which does recover in most situations, is somehow related to the ability to generate the speech. So we never think about cerebellum as being part of our speech circuitry except for the mechanics of mouth, tongue, lips, airway movement. But it clearly is controlling in some way the ability to generate language. So what do you see? More importantly, what don't you see? Cerebellum, did I make it magically go away? Yeah, I have incredible Photoshop skills. I have lifted off this. What's this? What's this that you can see sitting here? That's the arachnoid. So I have magically opened the arachnoid membrane and photoshopped out the cerebellum. Good? Yeah. No, what's more likely? This is somebody with no cerebellum. Okay? This, in fact, is talk about rare. This is a agenesis of the cerebellum. Let's take a look and see what we can see. This is these are, yeah. This is, can't really see 9 and 10 back here, but here you can. What are those? Would that be 11? Now, gone 5, 6, 7, 8, 9, and 10. Lower rootlets being vagus, upper rootlets being glossopharyngeal. All right? Can't really get a good look at probably right here. What are these? See those? Those would be? Those be 11. They're exiting the brainstem between the pyramid and the olive. Here's your pyramid. Here's your olive. These have to be 12. Okay? So this is an agenesis of the cerebellum. If you flip it around and look from the dorsal surface, you are looking through that slightly thickened meninges right into the fourth ventricle. And it turns out there is a tiny little nubbin of residual cerebellum up here. Probably not very, it was abnormal. There's a little nubbin there and a little nubbin here. So this was a patient, that was a patient who had lifelong ataxia. She never walked comfortably, but lived well into her 60s without a cerebellum, spoke slightly dysarthric speech, but had managed to be basically otherwise pretty intact. Here are a couple of other cases. This is one similar here, the brainstem. You can see a little bit of cerebellum. What are you looking into here? Fourth ventricle. Okay? That's the floor of the fourth. So if this is the floor of the fourth, what's running right here? A little deep, right here and here. Cross-section of the brainstem, fourth ventricle, you come just off the midline on either side, just ventral to it. Got this long bundle of white matter, runs really medially and longitudinally, okay? It's the MLF, okay? What nucleus would you expect to see right about here? Well, actually, I'm up higher. I'm at the low pons. 6. Then you'd expect to see here and here hypoglossus, and what would be in between them? Prepositus hypoglossus, the horizontal integrator. Okay? So this is a patient. This was a 38-year-old man. It's an old case report. Mentally retarded from childhood, but without physical limitations. Walk, run, stand without ataxia or dizziness. Speech is usually lucid and fluent. Enjoyed exploring and opening electrical devices. This is actually a forensic case. I wonder if he opened one inappropriate electrical device. And this is the final case I want to show you. It's reported twice, once in 1940 and again in 2010. It's a case of neocerebellar hypoplasia. Again, you can beautifully see the cranial nerves coming off and no visible cerebellum. And then in the pictures published in 2010, you can see here we're tipped up is this tiny little nubbin of cerebellum. Again, there it is. If you look, this person was admitted, he was in his late 60s. He described in this classic 1940s clinical syndrome. But the only thing we know about him is that he was a laborer which implies that he was not particularly motorically impaired. So you have to think about what sort of adaptations do you have to have in order to have essentially no functioning cerebellum for your extremities and be able to do work that keeps you employed as with your hands and moving around. The best part of this second paper is this, which is the acknowledgement. I am most grateful to my brother Robert Boyd. So they're both Robert Boyd. This is J.D. Boyd is the father. Robert Boyd is actually the brother of C.A.R. Boyd, for emptying his garage. The pictures, which actually showed that there was this little residual nubbin, were buried in a box in his garage. And when his brother got rid of moved, he emptied that box, said, "Would you like to see these pictures of Dad's autopsy case of agenesis of the cerebellum?" And his son, his brother, who was another pathologist, said, "Of course," and managed to get a second paper from it. In fact, in a very high-impact journal. All right, let's take a break, pick up at 1:15, and we will go through vasculature of all of the structures that we've covered so far. All right, so let's get going again. I think the last few will drift back in when they have their coffee in hand. So what we're going to talk about now is how blood gets to these structures. So remember that all of our neural tissue requires continual supply of blood for oxygenation, okay? About brain and cord together use about 20% of cardiac output for oxygen delivery. So we have to get blood in, and we have to get blood out. And both of those are critical. Failure to get blood in will lead to infarction from ischemia, lack of delivery of oxygen, okay? So hypoxia, as well as lack of delivery of glucose as a nutrient, okay? If you block blood coming out, what's going to happen? Okay, that tissue will not be drained properly. It will become residually ischemic because as you block that, you remove you block venous outflow. What's going to happen to venous pressure? Goes up. What happens if it goes up too high? You stop perfusing. If you stop perfusing, it doesn't matter if you have a blood supply that has plenty of oxygen and glucose in it. If it isn't getting to the tissue you care about, that tissue will become ischemic. Okay? So one can get infarctions either from loss of perfusion or obstruction of venous outflow. Okay? So we're going to use this as an opportunity to review all of the anatomy we've covered so far, and that's the exercise for the lab on Wednesday. Okay? When you look at that, you'll see that there's a huge grid to try and fill out. I would urge you to think about it a lot before you come to class so that when it's filled out, it makes sense and that everybody can participate in that. All right. So what happens if you suddenly lose blood supply? Okay. Well, if you suddenly lose blood supply and it persists for more than a minute or two, you will begin to accumulate injury. And if it lasts long enough to cause structural damage, that is the clinical syndrome known as stroke. Okay? So stroke is a neurologic deficit of sudden onset with loss of function associated with failure to perfuse. Okay? You can have that because you block one vessel. You can have that because you stop perfusing because you're in cardiac arrest. Or you can have that because you block outflow and you end up with a venous-based infarct, okay? The most common types will be embolic, meaning the clot came from somewhere else, versus thrombotic, it happened in situ. Something made the blood clot at that point in that vessel. Or it can be because a blood vessel ruptures and it is hemorrhage. If a blood vessel ruptures and the blood is going out diffusely into the tissue rather than through the vascular bed, you are not delivering it to its target. Okay? The critical thing here is that the pattern of deficit will be tied to the anatomic area that's involved. The pathophysiology of stroke is completely agnostic to the target area. Okay? The same thing happens in a stroke in cord, brainstem, cerebellum, and hemisphere. Okay? Yet the clinical manifestations will be completely different. What is true is that there is a very consistent, identifiable, and predictable pattern of these syndromes, and that tells us that, in fact, there is a identifiable, describable, nameable, predictable pattern of vasculature to these structures. Okay? If it was all random, then everybody's stroke would be unique. It would be personal. It would be the equivalent of a private mutation, but they aren't. Okay? And in some ways, the variability that does exist, reflects individual vascular anatomy and a little bit of exactly where the lesion happens. This is an area rich in eponyms, of which I will use only one, okay? Because it's the one that is the most common. It is another walk through 19th and early 20th century German, mostly German, but a little bit of French, and then the British feel left out, so they tack on a fourth name to the eponym of the people who describe these syndromes. In some ways, you can think about this variability like the patterns that you can see for the veins on the back of your hand, okay? If you compare yours to the person next to you, they are different, but not conceptually different. Everybody basically has a couple of them that they can see coming down along from the metacarpal interphalangeal joint, angling back. Nobody has like 4 that run in the perpendicular direction, okay? So that relatively consistent but uniquely personal gives a slightly different shape to the lesions in each person. If you want to learn more, and many of you I hope will, this is the place to go. This is Lou Kaplan's textbook on stroke. It will give you down to a vessel that has no name. Remarkably, there are structures within neuroanatomy that aren't named, okay? Down to exactly the distal leftmost branch of the posterior vessel feeding the thalamus on the right. That gets its own chapter, or paragraph at least, with a bold heading in Kaplan's book. It's wonderful if you want to learn about clinical descriptions of syndromes and how to think about them. In order to map them, we now have the ability to use imaging. You have to remember that all of these stroke syndromes that were defined in the 19th or early 20th century were done based on clinical exam and autopsy. But we don't need to do that. We can actually image vascular flow, and one can do that by basically shoving a needle in with contrast, shooting it and taking images. One can do that by using contrast in the vasculature and doing a CT, or using either contrast or intrinsic signal in blood and doing an MR angiogram. So all of these allow you to visualize where the blood vessels are, which ones are normal, which ones are abnormal. You can see comparable levels of detail in all of these. So if you look here, this is a CT angiogram. Where do you see an abnormality? Does it all look good? Where's the problem? High, low. Low. So what do you think? What do you think this might be? Carotid. And what's this? Carotid. Well, I mean, what's happening here? We've got blood going this way and that way. It's carotid bifurcation. Yes, the carotid body is there, but you can't see it. You're just looking at the lumen. Remember, all you're seeing is what's inside the lumen. So which vessel goes up there to the left? Internal. And then what happens? all of a sudden we've got this point where we've got just pinpoint blood luminal space. What would you guess is the most likely cause of this? Yeah, say it louder. Well, is this what arteriolosclerosis affects what caliber vessel? So it's mostly small vessels, small to medium arterioles. What kind of vessel is this? Big muscular artery. Major disease for big muscular arteries? Atherosclerosis. This is an atherosclerotic plaque just above the bifurcation of the carotid. Okay? So, let's think about those carotids coming up. So, we have the vessels that come up. We're going to have two major arteries. We're going to have the common carotid that bifurcates, giving rise to the internal carotid. That will come up bilaterally. And then we have two other vessels that we need to care about, which come off the subclavians. Okay? We have the vertebral artery on either side. There, and here it is on this side. And they come off the proximal subclavian after the takeoff of the internal carotid. Okay? So now we have four vessels that are going to ascend. The carotids come up anteriorly and laterally in the neck. The vertebrals, what do you expect them to be next to? Vertebra. Okay, they run right lateral to the vertebral bodies, up on either side. And now how are they going to get inside the skull? So, foramen magnum would be a good bet. But where are they relative to the vertebral bodies? If you wanted them to come in through the foramen magnum, where would you expect them to be? Let's just think. I've got my cord. I've got my vertebral body. If my vessel is next to the vertebrae, okay, where is it relative to the cord? What's between it and the cord? Well, what sits right around the cord? First layer meninges, leptomeninges. We've got our pia to the subarachnoid space and arachnoid. And then next, dura, right? Where's the vessel? Is it inside the dura? No, it's stuck out here outside the bone, all right? So how's it going to get in? Remember, the dura is contiguous as you go from the dural lining of the skull to the foramen magnum, and then you've got that sleeve of dura. So the vertebral artery is on the outside, right? Can't come in the foramen magnum. It actually comes in through its own foramen into the base of the skull and enters there, okay? The carotids will come to in a moment. So when we look at these running up, here are this is a CT angiogram reconstruction. This is the vertebral artery, here, 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 snakes around and then enters the skull through a foramen. Here's the carotid coming up. This is the external carotid, and this is the internal that will come up through the base of the skull. Okay. So those are what bring blood in. Two carotids on a carotid on either side and a vertebral on either side. That gets the blood in. We'll worry about how it branches in a moment. How does it get out? Well, if it comes in with arteries, it leaves with veins, all right? And we've talked about where the major vein destinations are already. They are the sinuses, okay? So a venous sinus is a large venous channel, okay? It's lined by endothelium. It sits here, the superior sagittal sinus. What's missing from this picture? Do you ever see the superior sagittal sinus sitting just like that on the top of the brain? No. What's it embedded in? Dura. Okay? Runs across that convexity, across the midline where the falx reaches the dura from the convexities. As it comes back, it joins, as I said earlier, with the straight sinus. What is the straight sinus in? Remember, the falx comes back, it hits the tentorium at the midline and is anchored right onto it. Okay? So it sits on the midline of the tent. We've got one wing of the tent and the other wing of the tent. And at that point where the falx comes down and you're at the midline is the straight sinus running back. And those two come together, and then we will have sinuses that run laterally. Transverse sinus. Where am I? Where's my pen? Oop. The transverse sinus here runs lateral. What's that going to be in? The dura. Dura of what, though? Well, it can't be the falx, because we've come to the end of the falx. And it's going out lateral. Yeah, it's where the tentorium comes up against the skull. Okay? So if you think about it, you've got at the midline, you've got the superior sagittal, comes back, and now tacked at the skull and the dura laterally, you've got the two transverse sinuses. Okay? They're going to come back and we'll eventually follow them further. But you've got that anatomy, okay? So, where do you think things from the posterior fossa are likely to drain their veins? They're going to go to the superior sagittal sinus? No. They're actually not even going to, almost nothing drains directly from brain into the straight sinus. So where are they going to likely go? Actually into the transverse sinuses, okay? How about things that are above the tentorium? Where do you expect them to go? Superior sagittal sinus. Right? So we've got two sort of major venous routes out of the brain into the sinuses, but they're eventually all going to come together. Okay? If we look at it from the inferior surface, okay? Is the cerebellum here? No, it's been removed. How is it removed? Cut across the midbrain, right? So a nice cut across the midbrain. Are you able to, if you do that, are you able to see the sinuses? No, they're hidden in the dura. And this dura here would be the tent. So that right here you would have the lateral leaflets of the tentorium. Here tucked up against the skull. But here, the junction between the left wing and the right wing of the tentorium, the straight sinus, and then coming into it from deep in the screen would be the superior sagittal. And this is up against the edge of the skull as well. So we almost never get the sinus off the lateral aspects of the skull intact. We can sometimes get it off the midline by yanking it off, but it's almost impossible to get off back there. Okay. So let's think about the cord. So where is blood going to get to the cord? Well, if all the blood supply that for the CNS, brain and cord, comes from vertebrals and carotids, they come from the heart, they come off the two subclavians, or in terms of one carotid, it's got separate origin, okay? And up they come into the skull. How are we going to get blood to the cord? Any ideas? What are you going to do? You need vessels that turn around and run with the cord. Okay? So we have these two entering vertebral arteries. Let me find my... Okay. Here's a vertebral artery and a vertebral artery. This is where they have penetrated the skull. As they run superiorly, they give rise to two, each gives rise to a branch that turns around and runs along the anterior surface of the spinal cord. And that is the anterior spinal artery. So if you think about the path of blood, it has gone from the heart, inside the skull, and then down with the cord through the foramen magnum. Okay? When we look at it, you will see on the cords, it is a tiny vessel. Okay? So there is a smaller posterior spinal artery that typically is generated off the posterior inferior cerebellar. They are very variable. These vary from person to person in terms of their size. This is actually the dominant arterial supply for the cord. When you look at the map, and we have to start thinking about these, we're interested now in what lies in a vascular territory. Here is the anterior spinal artery. Here's the anterior spinal artery, and its vascular territory will be something about like this. All of this will be supplied by the anterior spinal. So what's going to be involved in that territory? This is the anterior horn. This is conveniently labeled for you. Anterior lateral. This is corticospinal. Next to it will be rubrospinal. What will be down here? Any anterior corticospinal. What else will be in here and here? There are 4 more tracks total. Vestibular spinal, which has a medial and a lateral, and a medial and a lateral. All of those lie in this territory. What's the major thing that's outside of this territory? Dorsal columns. Okay? So, let's look at how big that is. So, this slightly thinnish white line here, that's a bit bigger than a hair, is the anterior spinal artery. It's tiny. Yet you rely on it for keeping your cord intact. And if you didn't have your cord being perfused, you'd be in a lot of trouble, right? So it can't run the full length of the cord. You just can't pump enough blood up the 2 vertebrals, through that thin vessel, down the cord, without needing to resupply the cord distally. And that's done by an anastomotic vessel that is known as the artery of Adamkiewicz. Okay? Comes from an intercostal. And remember that every intercostal artery travels with the intercostal branches of the nerves as they come back into the spinal canal, and usually one of them anastomoses in and is larger than everything else. It's usually, most commonly it is the T10 root, and it typically comes from the left. That's sort of if you look at a whole lot of people. But if it's at the T10 level, it's at risk for being disrupted with anything that damages the lower thoracic aorta and the abdominal aorta. So aortic dissections can lead to disruption of the artery of Adamkiewicz. And what would you get? Remove that reanastomotic blood supply for the distal cord. What would you get? Sensory and motor deficits bilaterally from that level down. And if it came in at T10, what would you expect that to be? You expect it to be sort of from low thoracic. You expect none of the proximal leg flexors or extensors to work, not just distal leg muscles, but complete lower extremity paralysis and sensory deficit. This is Adamkiewicz. He described this. He also was interested in cancer biology and thought all of cancer was caused by a parasite that he felt he had identified and was able to transmit person to person. All right. So when we think about vascular territories, the only thing that we know is consistent person to person is dorsal columns. So anterior spinal arteries, if you injure them, you will lose all function. How about your dorsal column function? Would you lose it as well? Well, it depends. If you have a localized lesion, dorsal column function that entered below will be intact. But how about dorsal column function that enters at that level? Might be impaired because you might well hit some component of dorsal horn and take those fibers out. Okay? But what if you have got Adamkiewicz and you lose everything? You will lose all that proprioceptive information below because you'll have injured the dorsal corns coming in. Just an example, This is actually somebody with a aortic dissection. And if you look at the cord, what do you notice? Well, does this stuff down here, where's my arm? Does any of this stuff look good? It's all fragmented and infarcted. How about your dorsal columns? There they are. They're pretty good. Notice here, what's missing? Dorsal horns, completely shot, completely gone. Notice there's some supply still from the dorsal vasculature for this side, for the corticospinal tracts, but not on the other side. There's asymmetry to the pattern of vasculature. But this is an acute cord infarct. No, here, your anterolateral is completely dead. Fibers need oxygen just as much as neurons do. Yeah. In order to maintain, they are just as dependent on ATP. And this is an example. This is what that cord looked like grossly. And here, in fact, is the aorta with the dissected blood in the wall. And that blood basically compromised the artery of Adamkowitz, and from that level down. The only thing you need to know is that these patients who have aortic dissections and repair of aortic dissections are typically in the surgical ICU, and it's only several days later, after the surgery or after their dissection, that somebody realizes that they haven't moved their feet since they were admitted. It's pretty common for neurology to be called to see them, not in the acute phase, but once it's well established. All right, how about venous drainage of the cord? Well, this is pretty heterogeneous, but the important thing that you need to know here is that there are two venous plexuses around the cord. One is a general plexus that will sit in the subarachnoid space, but the other sits in the epidural space. So why is there an epidural space? Yeah, so the dura is not attached to the bone in the spine. Okay? It sits separate from it in order to allow the spine to remain flexible. And there's a venous plexus there. That's the epidural venous plexus and the subarachnoid venous plexus. Okay? Those of you may remember the compounding pharmacy that prepared steroids for epidural steroid injection that were compromised or contaminated with fungus. Okay? So a large number of people who had this fungal contaminated preparation injected into the epidural space and ended up with cord infarcts because they ended up with fungal infection of the epidural vascular plexus and fungal infection there that both gave rise to venous infarctions as well as mass effect and cord compromise. Okay? So it was paper, it was in the New England Journal at some point. I don't have the citation there. All right. So let's think about cerebellum now. So cerebellum, and all of the pictures that you see in every book are far too complicated, unfortunately. Okay? And the vessels that we care about, here we are looking through the foramen magnum. Okay? So these are the two vertebral arteries that have entered the skull through their foramina on the lateral aspect, and are now rising up with the top end of the spinal cord and onto the medulla. We can see the branches that give rise here, find my dot, that give rise here to the anterior spinal artery that will turn and travel down the cord. We have two vertebrals that are going to fuse at the midline and give rise to the basilar artery. Is it labeled? Must be labeled someplace. Basilar. Okay? So we come in with two, we join with one, and at the very top of the basilar, we're going to branch again. Okay? So we've got the basilar artery coming from the two vertebrals. Coming off, typically described as coming off the vertebral just before they fuse, we will have the posterior inferior cerebellar artery. known as pica. Not to be confused with the dirt-eating behavior seen for iron deficiency that is also known as pica. Okay? Posterior inferior cerebellar artery. If you have a posterior inferior cerebellar artery, what does it imply? The existence of either a posterior superior cerebellar artery or an anterior inferior cerebellar artery. And it is in fact an anterior inferior cerebellar artery that we get in the cerebellum. And that comes off the very early segment. The proximal segment of the basilar is the where's my, oh, I'm up there, down here. The anterior inferior cerebellar artery, which comes off the basilar. So if I'm beginning to sketch this, I would draw my two vertebrals coming together to make a basilar. And off each of these, I would draw, this would be pica. This is vert. This is basilar. And then now I've said I have a ica. And then up here, I will have one more, and that is the superior cerebellar artery. Okay? So we have three cerebellar arteries: superior, anterior inferior, posterior inferior. Okay? So we now have some basic idea. One of them is way up towards the end of the basilar. Where's the end of the basilar look like it is? What cranial nerve is this peeking through? 3. So if the superior cerebellar is just caudal to 3, where would it sit? Pons, midbrain, medulla. It's just caudal to 3. So it sits at the upper end of the pons, okay? So if it sits at the upper end of the pons and it's going to be supplying cerebellum, what part of cerebellum would you expect it to be supplying? Think, visualize it in your head. Roll it around. Look from the front. Okay, that's where I am. Roll around. What are you going to be on? Be on that nice, flat, superior surface. How about pica? It comes in before you even get to the basilar, okay? Just at that low end of the medulla. Where is it going to go? It's going out lateral. What's it going to supply? That big, fat, inferior surface of the cerebellar hemisphere. And how about ica? It's sort of at the midpoint. It's going to do that sort of zone going out lateral as you go out from the CP angle. Okay? So where are those? Well, here physically, this is the vertebral. Here's the vertebral. Here's the basilar. So pica is coming off right over here. I can't even see ica. I've probably torn it. And the superior cerebellar is tucked right up there. So you can see what they will correspond to. This will be the pica territory, all of this. Ica's territory is pretty small in here, and all of that and the superior surface will be the superior cerebellum. We can skip the imaging there. So if you think about it now from the lateral aspect, okay? So we're talking about arteries that are supplying the cerebellum, but I've gotten rid of the cerebellum in order to see where they are. Because they are all starting at close to the midline. Ventrally, where's the cerebellum? It's all dorsal. So how are they going to get there? You got two routes. Either you can wrap around, or you could try and penetrate and go straight through. What's wrong with penetrating and going straight through? Well, how do you go from brainstem into cerebellum? What are the fiber bundles? They're those peduncles. Remember, they're not really distributed uniformly over the course of the cerebellum. So in fact, the vessels run around the brainstem and then to the cerebellum. So as you see here, if you look, you can see, here's your vertebral. Find my thing. Here's our vertebral. Then turns into the basilar. And then as we get to the top where we pick up cranial nerve 3, here we've got the superior cerebellar wrapping around the brainstem and then going to cerebellum. We have the anterior inferior at the low end of the basilar wrapping around and going to cerebellum. And we've got pica snaking along the lateral aspect of the medulla and going to the cerebellum. We'll skip the imaging for now. So if you now look at them and say, where are they relative to those peduncles? Because the peduncles are structures that are in the way. Superior cerebellar comes along the superior aspect of the middle peduncle. Pica comes from below. It comes up along the lateral aspect of the inferior peduncle and the inferior boundaries of the middle cerebellar peduncle. And then Ica is going to wrap around the sort of central portion of the mid peduncle and get to that distal cerebellum right on the surface. So here, if we look with the cerebellum in place, we can see superior cerebellar coming off the top end of the basilar, coming to this whole area here. We've got pica. We've got this small little zone of Ica that sits like this, and then pica does all of this. So now we come to the next concept, which is this lateral rim of the cerebellum sits between the boundary of, it's the distalmost territory of the superior cerebellar, and it's also the distalmost pica. So in fact, that zone that uses both vascular supplies requires, in order to be adequately perfused, that each of them makes its own contribution. Okay? So let's imagine we are in a hypotensive setting. Your blood pressure, your cardiac output has dropped to 70% of what it's supposed to be for everything else. What's going to happen to the distalmost vascular territories? Yeah, you're going to get rid, you're not going to be able to deliver adequate perfusion to every single part, okay? You're going to only be able to adequately perfuse some fraction of the way. So what vascular bed is going to be the most vulnerable? That which relies on multiple distal territories, okay? So the term for that is completely inaccurate is watershed infarct, okay? And why is that wrong? So what's a watershed? Who took geology courses? So a watershed is a place from which water runs, okay? That's the exact opposite. This is not a watershed. This is, in fact, a distal problem. This is at the worst opposite end, okay? So this is, in fact, a boundary zone infarct. It is the boundary zone between vascular territories that is vulnerable. And where would that vulnerability be? Right around that lateralmost rim is the nice flat surface that's superior cerebellar meets the nice curved surface that's pica. Right where they come together is where you will see infarcts and hypoperfusion. And we'll talk about this concept over the course of the next couple of weeks a bunch of times when we talk about boundary zone infarcts in other territories. No, it's misused all throughout neurology. Yeah, and we'll talk about them on next Monday. No, next Wednesday, because next Monday's a holiday. Okay. But notice, does this map onto the systems that we have for the cerebellum? Yes and no. They don't map onto the separation between vermis and hemisphere, but they do sort of map a bit between inferior portion, that posterior portion that's mostly cognitive, and the superior portion of the lateral hemisphere that's mostly true motor, so that there are differences in the syndromes that one sees, and especially in the types of recovery. So now with that structure in mind, we can think about the posterior fossa contents, the brainstem. So we have the same vessels feeding us, the two vertebrals and the basilar. And we'll talk about re-backflow of the basilar from the anterior circulation in a week or so. But where are they going? Well, pica, what did it drape? So first of all, the vertebral and pica, what are they draped over? Midbrain, pons, medulla? Medulla. What's the basilar draped over? Pons. What's the very top end of the basilar at? It's at the midbrain. Okay? So our midbrain is going to be supplied in part by the basilar and in part by the superior, the posterior cerebral that we'll talk about a bit. But these vessels, the superior cerebellar, ica, pica, and vertebrals, are all going to be supplying brainstem. But in addition, there are lots of other vessels that exit the basilar and wrap around the pons. Most of them don't get to the cerebellum, so they're not part of our cerebellar blood supply, but they are wrapping around the pons and providing blood supply to it. So for those of you who want to see an elegant article, I would send you back to this paper. I think it's from about 1940. And just so you realize, at MGH, our neuropathology service is known as the C.S. Kubik Laboratory for Neuropathology. C.S. Kubik was one of my predecessors as the head of neuropathology there. He was a neurologist and a neuropathologist. This was done with Ray Adams, who eventually became the chief of neurology at MGH, but at this time he was the neuropathologist at Boston City Hospital. And they looked at, it's a wonderful thing, I think I have the numbers here, they looked at 42,000 consecutive autopsies at MGH. That was probably about 5 years worth of cases. And 3,200 autopsies at Boston City. That was about the same 5 cases. They went through those records. They didn't do a computer search. They went through each one of them one by one, and they found a total of 15 cases of basilar infarcts. They looked at the anatomy of every single one. They had notes drawn at the time of exactly where the occlusion was, what vessels were occluded, and what the lesions were. This is where this sorts of pictures that I'm showing you come from. Well before anybody had CT, diffusion-weighted imaging and the like. So when we think about these, the vessels that are going to give rise are these main ones: vertebrals, pica, ica, basilar, superior cerebellar, and then this one called the quadrigeminal. Where would the quadrigeminal be going? What's quadrigeminal plate? Colliculi, the tectum. It's going to wrap around. And notice the basic architecture is that they originate ventrally and they wrap around the lateral aspect. When we see them coming around, you can see that they will be able to reach to the midline. Why can't they reach to the midline here? The cerebellum's in the way, right? But above and below, they reach the midline. So you begin ventrally and you arc all the way around laterally. In doing so, they basically follow this basic rule, that there is what we call paramedian penetrators, then short circumferential and long circumferential. So you basically divide this brainstem into 3 wedges. One close to the midline, one very far lateral, and one in between. And each one of those wedges can be susceptible to a small embolic infarct. And the exercise for lab on Wednesday is to think about what would be the differences between losing the structures in here and versus losing the structures over here. Can you tell the difference? And you should be able to, because different things are in different places. Okay? So this is the concept: paramedian, short, and long. Paramedian penetrators seen here are really important. Why? What are they mostly supplying? They come in on either side of the midline, pretty close in the palms. This is your basis pontus, right? See these things? They are tiny. I've tried to show you how big they are. I've zoomed in so I'm just past the focal plane. But they are, thin hair-like. If I lift the basilar artery up, we'll look in the lab, I'll come through. If we lift the basilar artery up, you'll be able to see some of them. They are important for keeping your pons perfused. People here read The Count of Monte Cristo? So there's this wonderful, people shaking their heads at me. So there's this wonderful description. Monsieur Nautier was sitting in an armchair which moved upon casters, so he's essentially in a full-body wheelchair. in which he was wheeled into the room in the morning and the same way drawn out again at night. He was placed before a large glass, that's a mirror, not a glass to drink, which reflected the whole apartment, and so without any attempt to move, which would have been impossible, he could see all who entered the room and everything which was going on around him. Sight and hearing were the only senses that remain, and they, like two solitary sparks, this is a great translation, remained to animate the miserable body which seemed fit for nothing but the grave. In short, his whole appearance produced on the mind the impression of a corpse with living eyes. This is a wonderful description of locked-in syndrome, okay? So why would you get that? Why would you have no motor activity but still be able to see and hear? Anybody know this book? Okay. So, how do you move your eyes voluntarily? What do you need? Cortex. And it has to descend. And what is it going to drive? Well, it's going to drive the motor system, but how does it get there? It has to get to the gaze centers. If you disrupt your palms, can it get to the horizontal gaze center? Can you get to the vertical gaze center? Yes. If you disrupt your palms, can your corticospinal tracts get to any place in your body? No. Where's your facial nucleus for moving your face? Midbrain pons medulla? Pons. Low pons. Can you move your face? Can you do horizontal gaze? Can you do some vertical gaze maybe? Yeah, tiny bit of vertical gaze. How about any other movement? No. Can you see? Yeah. How about hearing? Well, if you lose your basis pontus, where are your auditory fibers coming in and traveling? Are they in the basis pontus? Well, they come into pontomedullary junction, but where do they travel? Yeah, they're in the especially the dorsal cochlear fiber bundle is in the dorsal tegmentum. That's in a separate vascular territory, so you have hearing. Okay? Do you have any response? Well, maybe you can make a slight eye movement, and that's how this book was dictated, by slight upward eye movements. It was originally defined, locked in by Plum and Posner, although, you know, it's described by Dumas. Supranuclear deafferentation, paralysis of limbs and most cranial nerves. You have normal consciousness. You can typically have maintenance of vertical but not horizontal eye movements because you're not using the PPRF because you can't get stuff down to it particularly well, and you especially can't get down into through the MLF all the way down. And you can use blinking to communicate. Here's an example of a lesion. This one actually picks off the whole tegmentum, so this person probably also would have been deaf. You can see that lesion. But this lesion comes, in fact, from, and this is an infarct. I want to show you this just so that you get some sense of what can be done. So this is a clinical trial. This is actually now about 6 or 7 years old. This is a woman who has a microelectrode array implanted into motor cortex that's connected to the scalp through a pedestal. You can see the pedestal that's attached to the 100-pin connector that goes to the computer that's out of the screen. And you can see that she's got a little bit of motor activity, but nothing. She's very, very spastic. You can see her flexed position. But she is using her cortical motor activity to move the computer arm, move the mechanical arm. And then you see, she also has a lot of trouble generating the suction. It's a slightly viscous liquid, and she's got a lot of trouble getting the suction to get it up into her mouth, but she will eventually get it there. It's colored, so you can see it move. Here it comes. Not quite. Meanwhile, the guy in the back is trained to like show be completely poker-faced. And then she got it all the way up. Yeah. For those of you who are interested in brain-machine interfaces, I would suggest you seek out Lee Hochberg and his collaborators at the General. This is somebody who, at autopsy, who had 2 pedestals in place. They're moving now to wireless connectors, so you don't have to be wired to a machine. But if you look and actually see what they are, just draw your attention to, here I need to actually stand close and highlight it. But the recording electrode is right here. And if you actually look, you can see the small little 10 by 10 contact points. Each of those has essentially a 1.5 millimeter long electrode. It's just tapped down into the cortex, and the combination of single units that are being recorded from that is what drives that interface. So when we think about brainstem, we've got, yep. So they are in motor cortex, and they are trying to actually make a motor movement, but they are not sort of trying to simulate. That's what they're asked to do. And then the software and the analytics basically recognize patterns of activity and turn that into mechanical displacement. And so that by the time she gets to this trial, she has done numerous numbers of trials of moving it. So that the software, so there's a feedback loop of learning what the firing is and learning how to make a movement. Yeah. So these are placed neurosurgically, and once the wounds are healed, the person they get connected, they see quality of recordings, and then basically it's software learning that does the interfacing. Lots of interesting problems to tackle. Yep, purely electrical. There's purely neuronal firing rates, patterns, individual single units being fired, patterns of activity that then get translated into displacement on the mechanical arm, and then somebody can know, you can basically, once the software makes the link, you can basically do the movement. So when we think about these at the top end of the basilar, we have a little problem. So the basilar ends. So we give rise to these paramedian penetrators. Again, think about what structures are going to be in this zone and what you would expect to lose if you get an infarct. Here's our superior cerebellar artery. It sends branches that run pretty far around, but coming off this vessel here, which we didn't name earlier, which is the posterior cerebral artery, which comes right off the top of the basilar, we get the short paramedian, short circumferentials. So think about it. We get paramedian, short, and long, all at the top end. If you infarct the top of the basilar, you get a very distinct syndrome. You get visual deficits. Why would you get visual deficits, and why would you get abnormalities in vertical gaze? What's in the midbrain? Close to the midline? Yeah, interstitial nucleus of the MLF, interstitial nucleus of Cajal, your vertical pattern generator, your vertical gaze, and oculomotor nucleus, and the MLF, okay? You get sleepiness, we'll talk about that in a bit, but you get typically you get something called peduncular hallucinosis, okay? These are characteristically well-formed, not particularly threatening visual hallucinations, okay? And the mechanism for that is completely not understood. Okay? But it's a very characteristic triad. Where are we now? Medulla. So, paramedian vessels, well, what's close to the midline? Was that aspirin? Acetylsalicylic acid? What is it? Anterior spinal. That's paramedian. What's its territory going to include? pyramid lemniscus. Vertebral. What's its territory going to include? Olive. Ambiguous. What's this? Posterior inferior cerebellar. So we've got a paramedian, a short circumferential, a long circumferential. What are you getting here? What are these? Vestibular. What are these? Further lateral than the vestibular. There's only one thing. It's cochlear. Okay? What is this? Tract and nucleus of 5. What's it doing? Sensory information from one side of the face and the second order sensory neurons from that side of the face. Okay? So, pica covers all of that area. Vertebral, this intermediate zone, and the anterior spinal, the paramedian zones. The lower down you go, what have we got here? We've got, again, pica, vertebral, and anterior. What are these? Nuclei of the dorsal columns. What are they the source of? Medial lemniscus. All of that, those are the second order neurons for your sensory information. They haven't yet crossed the midline. So a lesion on the left would give you deficits referable to which side of the body? Left. Okay? If you go up here and you have a lesion here that affects the left side of the medial lemniscus, it will be lesions on what side of the body? Right. Ah, so where you are will determine whether you affect the same side or the other side. That's what you have to think about when you think about that table for Wednesday. Here are just a series of walkthroughs showing you the various boundaries. They're in the slides for you to look at. You should have a rough idea of what lies in each territory. But remember that the boundaries are not fixed. They will be slightly variable person to person, but not widely variable. One of the lesions that you should know about is the so-called lateral medullary syndrome. This is the only one that has a name you need to know about, which is Wallenberg. Pretty sure it's with a U. I can't remember whether it's a U or an E, but Wallenberg syndrome is lateral medullary. What is lateral medullary going to involve? It'll involve inferior cerebellar peduncle. It will involve vestibular nuclei. It will typically involve fibers of 10 as they exit, and it will involve portions of the tract and nucleus of 5. Those are the critical things to think about. What? It's with an E. Jean is correcting me. Thank you. It's Wallenberg with an E. Okay. Here are all the components of it. You should be able, if you look at this table, to think about what anatomic structure gives rise to each one of them. Then as we come up into the pons and the midbrain, again, we remain the same concept of paramedian, short, and long circumferentials from different sources, and each one will give a syndrome that you should be able to sort of put together. All right, I'm going to stop at this point so we get to lab, because I do want to cut cerebellum. I will tack this bit of venous drainage of cerebellum. Venous drainage in the posterior fossa is, again, incredibly heterogeneous. The basic idea is that things that higher up tend to drain upwards. Things that are down low tend to drain downwards, but it's very variable person to person. That's in there. Skip that. And here we can see just what part of cerebellum is infarcted. I'll tell you that the boundary between normal and abnormal is right here. So if this is a duck sitting on the water, this is all the stuff under below. That's inferior cerebellum. What vascular territory would you think that it is? Pica. That is a full pica infarct seen laterally. How do you know you're lateral? What don't you see? Well, you don't see the fourth ventricle, and you don't see the aqueduct at all, so you know you're off the midline. All right. in lab, I will come through. What I want to do is I want to take a cerebellum off one of the half brains. I'll take the midbrain off, take the cerebellum off, and then ideally slice cerebellum parasagittally so you can get a look and actually see cerebellar deep nuclei. All right, I'll come through the groups and help. All right. Whew.